would like to thank the Pan American Trauma Society and the Colombian Trauma Society, particularly my dear friend Maria Fernanda, for inviting me to be here today. It's always nice to come back to Colombia, particularly to Medellin. Talk to you this morning briefly about non-operative management of splenic injuries, and I will focus on one aspect of non-operative management, which is angiographic embolization of splenic injuries. And I may leave you with more questions than answers, because this is a very confusing topic, and I am actually particularly confused. And sometimes I really don't know, by reading all the guidelines and all the papers, what is the right thing to do. So maybe I'll bring to your attention the confusion that I have in my mind. I would like to start this talk with a quote from Albert Einstein, and it's the definition of insanity. Insanity is repeating the same actions over and over, again and again, and expecting different results. And I think you keep that in mind, because you understand why I'm putting this up at the end of the talk. I think this is a classic paper published by Leon Pachter back in 1998 that really demonstrated the change in paradigm in management of splenic injuries. Until between 78 and 89, most of splenic injuries were treated by splenic repair or splenectomy, and a small number of cases were treated non-operatively. And starting in the early 90s, there was a complete change in paradigm, and most injuries were treated non-operatively, and the number of splenectomies and splenic repairs dropped dramatically. We've seen this in our own institution. This is data from 2005 to 2009, and you can see in red is non-operative management, and has been stable over the last several years. About 70% or so are treated non-operatively, but still there is a small number of patients that come in hemodynamically unstable that go to the operating room and get their spleen taken out. So for most of us in modern trauma centers, patients come in and we look at them and we examine them, and if they have signs of a surgical abdomen, they go to the operating room. If they don't, we look at their vital signs. If they're unstable, they go to the operating room after DPL, or more recently FAST. So a positive ultrasound indicates, in hypotensive patients, indicates need for operation. But if they are hemodynamically stable, they undergo a FAST. If the FAST is positive, showing free fluid, then the question is, where is the fluid coming from? We get a CT scan, and sometimes we find a splenic injury. So if we find a solid organ injury, and there is no active bleeding, no blush, patients are usually admitted to the intensive care unit for a day or so. They have their vital signs monitored, and they are treated non-operatively. If they have active bleeding, some folks, like myself, takes them to the operating room. Others would take them to the angiography suite for angioembolization, and this procedure can be successful, and then they are back into the non-operative arm of the protocol. Or if it's unsuccessful, then they go to the operating room and they have the spleen taken out. So it's pretty straightforward. I think most of us practice this way. The real question is this: whether or not we are pushing the envelope too much to keep those folks in the non-operative management arm of the protocol, and eventually getting trouble later on, 3, 4, 5 days after they come in. And again, like I was talking to Dr. Peitzman a few minutes ago, we make a simple problem a big problem. So that's what I want to talk to you about. So criteria for non-operative management, obviously hemodynamic stability, everybody knows that. Some patients that are treated non-operatively will fail, particularly if they develop hypotension, if they are unresponsive to fluids. This is very important. Grade 4 and 5 injuries, they fail the most. So some of us are arguing whether or not those patients should be treated non-operatively, or they should be taken immediately to the operating room, because the failure rate of grades 4 and 5 injuries, as I'm going to show to you, is greater than 50%. But definitely contrast extravasation on CT is one one issue that has been brought up to our attention in many publications as a reason for failure. Others have looked at the amount of hemoperitoneum on initial CT, pre-existing splenic disease for sure, age greater than 55 years, etc. So yeah, some cases go well, some patients will fail non-operative management, and this is an example. I put this up. This is a recent case of ours. This woman was about to go home on day 5 after being treated non-operatively. She was 55 years old, so she was right there at the 55-year mark. And on the day of admission, she stood up, went to the bathroom, and dropped on the floor and became hypotensive. We took her to the operating room, and she had a delayed rupture of the spleen. And as you can see, she had a very thick capsule. Here, she developed a subcapsular hematoma that contained that hematoma for some time, but that kept growing, and she was going to die at home if she hadn't dropped on the floor and became hypotensive. So, again, some cases will fail. What happens if you see bleeding during the observation period? So, you are treating non-operatively, and then the patients drop their blood pressure, or the hematocrit keeps dropping. If the patients are still hemodynamically stable, you can repeat a CT. If the CT is unchanged, you look for other causes. But eventually, when you repeat CT, you see pooling of contrast, or you start seeing things in the vasculature of the spleen that were not apparent in the initial CT, and those cases are best treated by angiographic embolization. Now, second quote, perhaps if we go forward in the search, we may stumble upon the thing we are looking for, but if we stay where we are, nothing will come to light. So it is important that we question our concepts and what we consider standard of care to make sure that we are always doing research and that we are always looking for an opportunity to change to better take care of our patients. So this brings me to the topic today, splenic artery embolization. We know this procedure has been used widely in the management of splenic injuries. Was reported back in 1981 for the first time, has been advocated to increase the success rate of non-operative management. So you start your non-operative management protocol, you insist on it, you do angioembolization to keep the patients on that arm of your protocol. However, patients have to be hemodynamically stable and have a blush on CT. That's the most common indication. Eventually we see pseudoaneurysms, and those can be embolized as well. And if they bleed after a period of observation, they may be suitable for this procedure. Now, the problem is that we are divided. Half of us think this is great, half of us think this is not great. And that's the controversy. So papers like this, have we gone too far, have come out. This is from Bill Chaffee's Trauma Center and Walt Biffle. They really questioned this, and basically they decided to review splenic embolization and to look at predictors of failure. They look at a 5-year period retrospective study, and they found 221 patients in their trauma center. 25% of those went directly to the operating room because they were hemodynamically unstable on admission, but they still had 124 of 165 or 75% that were managed non-operatively, and of those, 25% were taken to splenic artery embolization. Overall failure in their series of non-operative management, consider all grades, was 14%, and obviously, like just everybody else, they found that failure rate increased with increasing injury grade. So the more severe the injury, splenic injury, the higher the likelihood of failing non-operative management. But I want to bring to your attention this table. This is non-operative management, no embolization, and embolization. So 165 total non-operative patients, 14% failure rate overall. And again, grades 3, 4, and 5, more severe injuries, they failed the most. So you see 40% failure rate in grades 4 and 5. Now, in the group of patients that underwent embolization, particularly grades 3, 4, and 5, they had a failure rate of 40% as well. So overall failure rate of angioembolization, consider all comers, is 27%. So here's a procedure that you do to stop the bleeding, and it fails 27% of the time. So a quarter of the patients that undergo angiographic embolization fail. So we need to keep those numbers in mind. And all occurred at approximately 40% for grades 3, 4, and 5. So the ones that need the most are the ones that fail the most. So it begs the question, are we trying to do too much instead of taking them to the operating room and get done with the problem right away? They also find that of the 41 patients who failed embolization, 36% had moderate to large amounts of hemoperitoneum. So maybe if you have a high-grade injury and a large amount of blood in the abdomen on CT upon admission, you could make the decision to go to the operating room rather than to angioembolize them. And they use different methods for angioembolization, gel foam, coils, etc. The bottom line is that overall, 27% will fail. 71% of the patients that fail when active extravasation was seen on angiography, and they also had hemoperitoneum. So if you have a blush, a high-grade injury, and a large hemoperitoneum, why do this procedure if a quarter will fail? Another paper, this is from Juan Duchesne, a very interesting study. They looked at 30 months prior to splenic artery embolization and 30 months after splenic artery embolization became available in their trauma center. So they call it the pre-embolization era and the embolization era. Basically, they found a higher incidence of ARDS in patients that were embolized. So you keep those people in the hospital, you submit them to an invasive procedure, they get a second hit, and they may develop more ARDS, 5 versus 22. Higher rates of septic complications in patients that were embolized as well, splenic abscess, sepsis, and pneumonia, 5 versus 12%. So these are the complications. ARDS, they required more blood, they had longer hospital stay, and they had higher mortality. So in low-grade blunt splenic trauma, they conclude in that study that splenic artery embolization is no better than operative intervention in terms of feasibility, safety, and effectiveness. In high-grade injuries with contrast extravasation, they found equivalent mortality rates and length of stay between operative management and non-operative management with proximal splenic artery embolization. So it's not superior. It's at best the same as far as mortality goes, but they found higher mortality rate if patients failed non-operative management after splenic artery embolization. So this is important because it relates to the number of complications that occurs after splenic artery embolization, and obviously higher rates of sepsis and ARDS, as I showed to you. This is data from Boston, and they looked at their patients' immediate splenectomy, the ones that come in hypotensive, expectant management or non-operative management, embolization, and splenic salvage. So if you take people straight to the operating room when they come in hypotensive, the percentage rate of complications is 8.7, and they are related to pancreatic leaks and eventually gastrointestinal fistula. Now, if you treat them non-operatively, complication rate's 12.5%, and the most common complication is bleeding. So you observe them, they bleed, that's a complication. Now, interestingly enough, if you embolize them, complication rates, again, 27%, the same percentage of the previous 2 studies that I just showed to you. And guess what? The most common complication is bleeding. So you are doing a procedure that fails a quarter of the, 25% of the time in a quarter of the patients. It's supposed to stop the bleeding, and the most complication is bleeding. So why are we doing this? So we got to ask that question. And if you do a splenic salvage, complication rates very similar to non-operative management, and again, complication is bleeding. So here you have it, immediate splenectomy, the most aggressive way to treat it, complication rates very low. So we know how to do this operation, we can do this effectively, we can do this quickly. And then the complication rate goes up dramatically if patients are treated with splenic artery embolization. Interestingly enough, that all the complications in the group that underwent splenic artery embolization were related to bleeding. None became hemodynamically unstable, but all required splenectomy. So they just got the operation that they should have gone in the first place several days later. This is not happening just in the United States. This is data from China, and they show the same thing, major complications after splenic artery embolization. And you can see splenic infarct, bleeding, splenic atrophy, 7 major complications in 6 of 21 patients, or 27%. Again, the same number, 25-27% complication rate. And most of them, when they develop a complication, they need the spleen out anyway. And then other complications, minor complications, fever, pleural effusions, partial splenic infarct, again, 60% of the patients. So splenic preservation in SAVAGE are associated with increased complication rates in China. They require frequent patient reassessment to identify those that need further intervention. So what's the bottom line? Just to wrap this up for you. Active extravasation, in my opinion, active extravasation of IV contrast from the splenic parenchyma on CT is a sign of vascular injury, is a predictor of failure, particularly if there is moderate to large amount of hemoperitoneum on CT. Splenic SAVAGE with embolization is no better, based on the data that I just presented to you, than operative intervention in low-grade injuries, and has an increased morbidity and mortality in high-grade injuries, particularly when it fails. Active contrast extravasation on CT in grades 3 through 5 injuries should undergo splenectomy, in my opinion. That's how we've been practicing after we had to deal with some disasters after splenic artery embolization in elderly patients with severe injuries. Why we think this is important? Because there is a higher complication rate with splenic artery embolization. There is higher mortality rates with splenic artery embolization when it fails. If non-operative management fails after splenic artery embolization, which again happens about 25 to 30% of the patients, most will need splenectomy anyway. So in summary, blunt injuries to the spleen can be managed non-operatively. CT plays a vital role in decision-making. Hemodynamic stability is mandatory for non-operative management, and contrast extravasation on CT increases the likelihood of fail. So I'll leave you with last thought. Only a dead fish goes with the flow. Swimming upstream the current was slowly taking them to their destination. And in the process, their actions were making them much stronger. So again, we need to think about what we do. We need to question what becomes the standard of care based on a few studies here and there. There are a lot of personal experiences in this topic, and I'm sure that there is the other side of the story. I just present to you a biased one side, which is the side I believe is the one that we practice. But more importantly, I think that the message is to make sure that we always question what we do and we look at the data that's out there critically. Thank you very much.